Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion on diffuse lung diseases, today we're going to be talking about cystic lung disease. The first one we'll talk about is pulmonary Langerhans cell histiocytosis. Now, PLCH is a smoking-related lung disease, and that said, nearly 100% of adults with pulmonary Langerhans cell histiocytosis are smokers. Now, the other smoking-related interstitial lung diseases, aside from emphysema, are respiratory bronchiolitis, interstitial lung disease, RBILD, which we spoke about when we're talking about interstitial lung diseases, and desquamative interstitial pneumonitis, which we again spoke about. So now we are adding PLCH to the list of smoking-related lung disease. Now, it's possible to have multiple smoking-related lung diseases present simultaneously. Pulmonary Langerhans cell histiocytosis may present as a spontaneous pneumothorax, and the disease in adults is most often isolated to the lungs. However, you may have lucent bone lesions, diabetes insipidus from inflammation of the pituitary stalk, that's hypophysitis, and even skin involvements can occasionally be seen. In addition to Langerhans cell histiocytosis, the differential diagnosis for diseases that affect both the lungs and bones include malignancy, tuberculosis, fungal diseases like blastomycosis, histoplasmosis, coccidiomycosis, among others. Sarcoidosis and Gaucher's disease also can affect lung and bones as well. The first detectable abnormality in the lung for pulmonary Langerhans cell histiocytosis is nodules, and these nodules are seen to be associated with the airways. As the disease progresses, the nodules would cavitate and resultant irregular cysts predominate. The natural progression is from nodules to cavitary nodules and then to irregular cysts. At any point in time, a patient may have nodules only, or nodules plus cysts, or cysts only, or any combination of these. Radiographic and CT findings include upper lobe predominant cysts and irregular peribronchovascular nodules, and these ones will be seen to be sparing the costopharynx sulci. There's a sign we call the Cheerio sign in Langerhans cell histiocytosis, and this refers to pulmonary nodules with a central lucent cavity. This cavity is supplied by a patent bronchus, so you would, on the axials or in cross section, you would see a nodule with a lucency in the middle, looking like the cereal Cheerio, the Cheerios, those breakfast cereals. Smoking cessation is critical for stopping the progression of pulmonary Langerhans cell histiocytosis. However, the cysts will not resolve. So in these images, these CT scans show pneumothorax here and also clearly delineates these upper lobe predominant cysts. You can see multiple irregular cysts in the upper lobe, and then lower down we see multiple nodules. This was a case of pulmonary Langerhans cell histiocytosis, and we clearly see nodules, we see cysts as its presentation on CT. The next one we'll talk about is lymphangioleiomyomatosis, LAM. This is a diffuse cystic lung disease caused by bronchiolar obstruction and lung destruction due to proliferation of immature smooth muscle cells in small vessels, in lymphatics, and in bronchioles. Approximately 1% of patients with tuberous sclerosis have lymphangioleiomyomatosis. Tuberous sclerosis is a triad of seizures, mental retardation, and adenoma sebaceum. There are other radiological features that point to tuberous sclerosis, but that is beyond the scope of this discussion. Now, sporadic lymphangioleiomyomatosis is seen in women of childbearing age or older. And in LAM, the cysts do not disappear over time, just like pulmonary Langerhans cell histiocytosis. Now, lymphangioleiomyomatosis is associated with pneumothorax and chylous pleural effusion. On CT, lymphangioleiomyomatosis shows numerous thin-walled lung cysts. In contrast to Langerhans cell histiocytosis, these cysts tend to be round and regular. Also, LAM affects the lungs diffusely, while Langerhans cell histiocytosis is upper lobe predominant. So in these images, this first image shows end-stage lymphangioleiomyomatosis with severe cystic change in the right lung as well as moderate pneumothorax. There's also some cystic change seen in the left lung as well. This is the second patient, and this shows a less severe disease with multiple smooth-walled cysts, as we can see, diffusely distributed throughout the lungs, and not too clearly shown. There are mild bilateral effusions here, likely chylous effusion as it's associated with lymphangioleiomyomatosis. The third one we'll talk about is lymphoid interstitial pneumonia. This is both a clinical syndrome and the pathologic diagnosis. It's actually one of the patterns of interstitial lung disease that we spoke about earlier, though I left this out deliberately because I knew we were going to discuss this when we're talking about cystic lung diseases. So lymphoid interstitial pneumonia is exceptionally rare as an isolated idiopathic disease, and it's most commonly associated with connective tissue disease, especially Sjogren's syndrome, although it can be seen with other conditions like HIV as well. The histologic hallmark of lymphoid interstitial pneumonia is diffuse infiltration of the interstitium by lymphocytes and other immune cells, with resultant distortion of the alveoli. Lymphoid interstitial pneumonia imaging most commonly presents with cysts and nodules, though cysts alone, nodules alone, sometimes ground glass, or even interlobular septal thickening may also be seen. The scattered, thin-walled perivascular cysts are thought to be due to air trapping. Lymphoid interstitial pneumonia can be complicated by pneumothorax in advanced disease when these cysts rupture. So in this image, it is an unenhanced axial CT, and it shows patchy ground glass opacity, scattered perivascular cysts all around, and a right-sided pneumothorax. This was a case of lymphoid interstitial pneumonia. The last one we'll talk about is Birt-Hogg-Dubé syndrome. It's an autosomal dominant mutation in the folliculin gene. It causes fibrofolliculomas, that's skin nodules, and some renal tumors, especially renal cell carcinoma and oncocytoma. We also have predominance of renal cysts and pulmonary cysts as well in Birt-Hogg-Dubé syndrome. Spontaneous pneumothorax is a common feature, and on imaging you would have lower lung predominant polygonal or cysts that appear floppy in the subpleural or perivascular areas. So to summarize, this table shows us a brief summary of the characteristics of the cystic lung lesions that we have spoken of. In lymphangioleiomyomatosis, it's diffuse in distribution and you have many cysts, thin-walled regular cysts. In pulmonary Langerhans cell histiocytosis, it's mainly upper lobe distribution, but it also has nodules as well. It may cause pneumothorax, and the cysts are not as many as in lymphangioleiomyomatosis. In lymphoid interstitial pneumonia, it's lower lobe predominant, just like most of the other interstitial lung diseases. Also has nodules, and the number of cysts are not really that many. In Birt-Hogg-Dubé syndrome, also lower lobe predominant and has few cysts. So this brings us to the end of diffuse lung diseases. The next thing we'll talk about is the mediastinum and all the conditions and imaging features that we may see in the mediastinum. But we will start off with the anatomy of the mediastinum. Thank you very much for your attention, and I hope you have found value from this video. If you have, give it a like, give it a comment, subscribe if you have not subscribed yet, and share with someone who you feel would find value as well. See you in the next one.